who are going to talk very specifically about a topic which is grappling the whole US healthcare. It's all about how we can move from compliance to transformation, leveraging the CMS interop rules specific around 0057 final rule that has been released. Before I get into this core of the discussion, I would like to, as I said, introduce my esteemed panel, starting with Mark. Mark, would you please introduce yourself?
Yeah, hi, great to be here. So Mark Scrimshaw, I'm Chief Interoperability Officer at Onyx. My background includes actually being at CMS as the first person on the Blue Button 2 project. And since then, having seen that launch for 53 million Medicare beneficiaries, we provide the capabilities to payers to basically do the same thing. I'm also retained by HL7 as part of the Da Vinci project, where I am the author of the Payer Data Exchange Implementation Guide that is recommended by CMS in their 0057 rule. Great to be here. Thanks.
Thanks. We have the guru himself. Thank you. Tony, please introduce.
Yeah, hi, I'm Tony Trinkle. I was formerly the CIO at CMS and got involved in implementing many of these types of rules over the years. And since I left CMS, I worked first at IBM and the last number of years as a consultant running T. Trinkle Consulting.
Thanks, Tony, for being on this panel. And finally, welcome, Manjunath. Please introduce.
Hey, thank you, Nitin. First of all, thank you for bringing us all together here. I especially am very honored to share the floor here with the two of the finest experts in the industry, the thought leaders, Tony and Mark. Thanks for joining us. So yeah, my name is Manjunath Yaragunta. I go by Manju. I'm the Chief Business Officer here at LTIMindtree. I'm responsible for our healthcare business. In my role, I'm responsible for the strategic direction, growth, and operational performance of the business unit. So once again, very excited. Thanks, Nitin, for getting this together.
Thank you so much, Manju. Couldn't agree with you having this panel on the call. And myself, Nitin Shere, I'll be moderating this discussion. I'm part of healthcare's strategic business growth as a head of healthcare. So yeah, it's all my pleasure to take this discussion forward. So the first section of our discussion is all about, let's just warm up around and understand what these interop mandates are. And I'd like to start with Mark himself. Mark, what are these mandates, interop mandates are, and how are they relevant to health plans, right? And at what stage in this entire life cycle are they with respect to each of these mandates? Would you please share some thoughts on this?
Yeah, so let's start at the beginning. CMS-9115, you may recognize the number, covered the patient access rules. So it's interoperability and patient access. And that laid the groundwork where beneficiaries, health plan members are able to go to their health plan, use an API using a consumer health app, and they can connect and download that data. Well, what's that data? It was basically their claims information. It could include their clinical information, even their formulary information. And there was also the ability to actually look up for providers, finding in-network providers. So health plans, particularly Medicare Advantage and Medicaid, needed to implement that capability. Why is that relevant? Well, last year, CMS released their 0057 rule, which was the prior authorization rule. The focus there has been on prior authorization, but there is a lot of other parts in that. There are really 4 pillars to 0057. Patient access API, what you implemented will get upgraded. It will have more information, including prior auths. It will have more clinical data, and it will have things like vision and dental claims that your members will be able to retrieve. There is then also a bulk API that provides provider access. So your in-network providers will be able to come knocking on the door and say, tell me what you know about my patient. And then there is, as we know, members move from plan to plan. So CMS requires a payer-to-payer API that allows a member, when they move, to go to their new plan and say, here's my information from my old plan, go get my data, and the payer will be able to go and bring forward 5 years worth of data, which can really help on care management planning. And then the fourth pillar, the really big one that everyone's focusing on, is putting in place a standardized way for checking, do I need a prior auth? If I do, what do I need to provide you? And then tell me what the result was, and yield real efficiency, both on the provider side and on the payer side. Back to you, Nadine.
Oh, thank you so much. I think you've given us the overall value chain in terms of what exactly those impacts are. But now let's double click on very specific to the latest rules, and I think that's very important in terms of the value eventually it will bring in, right? So would you please elaborate on the CMS-57 requirements, including its significance and overall impact to all of the stakeholders in the ecosystem?
Yeah, so when payers implemented the original interoperability rule, there's been a growing number of members and beneficiaries use that data, but there's still a lot of barriers to that occurring. What CMS has done is really following their own path, in that they had made available data to ACOs, accountable care organizations, and also to providers through a couple of APIs that really build off of the blue button to API. And really, CMS is basically saying to payers, you need to do the same. And because of the way they structured the rule, where, for example, providers will be able to access data in bulk about all of the members that have been attributed to them, they will, by default, members are opted in to that API. So there is going to be a lot more data that can be exchanged between payers and providers than really was previously possible. And then on the payer-to-payer side, there'll be this opt-in for a patient, in that when they go to their new plan, they'll say, here's my old data, go find my plan, go bring my data forward. So I think we will see vastly more data flowing. Then the prior authorization API coming into place, there's a requirement to not only release the information about the prior authorization decision, but also the supporting clinical information that went into the decision. That's going to mean that payers will have vast amount more of clinical data that is coming from providers than they may see today. All of these things really come together because that data has to flow into the Access APIs. It's going to be available in standard structured form. And that really opens up a lot of new possibilities.
Makes sense. Absolutely. I think that's pretty important, right? And I assume that, not rather assume, it's confirmed that this will be only for medical necessity, not for the drugs related at this point of time, right?
At this point, payers could choose to implement medications. Okay. In fact, Washington State are going live a year earlier and are requiring medications to go through these prior auth APIs by 27. But it is an option for payers. CMS is basically saying, we will look at that later. So at some point that will become, we expect, mandatory.
Absolutely. Thanks, Mark, for this. I'll actually move to Tony now. Tony, I have a question for you, right? I mean, now that we understand what are the payers, providers, and everyone trying to implement, but very specifically to payers, right? What do you think are the key immediate steps they should take as we speak to be on that path of compliance, very specifically to the 0057 final rules, both from the IT and the business perspective, right? Do you think they are in danger of if they haven't started as we speak?
Yeah, thanks, Nitin. You asked a number of questions, and I'd like to just kind of follow on what Mark said. Mark was talking about it from a fairly regulation-based level, and talked about some of the key changes that are going to happen over the next several years. So when you take that and try to turn it into IT and operational changes, there's a lot of work you got to go through. First of all, you really should form a team of people from the affected business and IT areas and begin to really understand the requirements and how they'll affect both your current business processes and your IT systems as well. So what they should be doing, if they haven't done already, is map the current end-to-end states and the to be states and the various options you might have. Start looking at, your budget, the level of effort, the timing, the impacted internal and external stakeholders. Mark talked about the providers, and the other payers as well. How do you integrate with them? A key part of this to me, and I'll talk about this a little bit more later, is how do you communicate these changes that are going to be made to providers, to your members, and to others. And also, every payer has other operational deadlines that they have to deal with, such as enrollment periods and others that come up during the year. So how do you begin to integrate what you need to do here with some of the other major operational needs you have? Because in some cases, you'll be relying on some of the same IT and business personnel to make some of these changes. So a final thing with that is, assess the current level of knowledge and skills to do the changes, both internally with your own staff, with your current contractors, and then what types of external expertise you need. Where are the areas where you lack it? How much do you understand about Firebase APIs? How much do you understand about the changes that are going to need to be made? And those kind of things are things you need to do as soon as possible. And you mentioned the whole issue of non-compliance, as Mark pointed out, and I'll just take it a step further. There's a lot of changes that will be starting in January of next year. So things such as, providing information and, reduced response time. And then when you move to the prior auth API, starting to understand the benefit plan, the network status of providers, the services ordered, there's a number of things. So we're talking about January of 26 for some of these to come into place, January 27 for a lot of the APIs to come into place. So if you haven't started the work now, you're really behind the eight ball, as we would say, because of the fact that you got to get things into your budget. You got to make sure you have your resources, and you really got to understand the whole impact of this change. Because just a final note, as Mark said, this is something, and we'll talk about this in a few minutes as well, but this is something that's not only impact what you're doing to meet the mandate, but how does this really enable you to change your business processes going forward?
Absolutely.
There's a couple of things I'd like to build on that Tony pointed out there. One is when CMS put this regulation out as a proposed rule, they said it could take a plan 30 months to implement. We're now down to 23, right? One of the reasons behind that is that many plans do not do prior auth themselves. They farm it out to other vendors. And so one of the organizations to really engage may be your procurement, because you may need to be putting in place contractual changes to make sure that those vendors are going to give you the data you need to comply with the rule and give it to you in a timely manner.
And so just to look at the scope of that, Mark, in 2023, there was 53 million prior auth determinations made by plans just for Medicare Advantage, 53 million. So we're talking a very large scope when we start looking across these different businesses that the plans will be engaged in to meet this.
Fair point. I think they need to take control. They need to take the ownership. And that's the key, I think, message as you speak. Moving on to Manju, while we're still discussing on the base and the interop mandates, how is LTIMindtree as a healthcare solution and services provider perceiving these mandates from their standpoint? That would be really helpful to understand that perspective as well.
Sure, Nitin. I'll probably answer that from a few different perspectives. Starting from an industry view, we all know the industry has always been aspiring to, for the patient data to be traveling with the patient, from payer to payer or payer to provider, provider to provider, and so on. And I think these mandates are going to make that happen, right? So, from that perspective, it's a great milestone for the healthcare industry. The other thing is about the standards. We are, this mandate is going to make the HL7 FHIR as that standard, for healthcare data interoperability. So I think that brings a lot of standardization in terms of data interchange, between the entities. Now thinking from a stakeholder perspective, I'm again referring to providers and members specifically. When the mandates are implemented, and like Mark and Tony were alluding to, as we look through, the transformation, the other benefits of, beyond just complying to the mandate, I think we're going to see a very significant improvement in member-patient engagement, and improved operational efficiencies. We'll see enhanced care coordination, better patient access, ultimately driving better, patient outcomes for all the entities involved, right? So I think that's going to be a pretty big plus for us. Now, thinking from the healthcare entities, organizations that are trying to become compliant, that are required to be compliant, I think they need to understand and realize that these are fairly complex implementations. I mean, this needs you to think from all from an EMR integrations to payer provider workflows, admin rules, adjudication rules, and a lot more, right? So these are complex programs. You need to think through the whole spectrum. So this will need a pretty holistic analysis versus just looking at the rules and saying checkbox and see what I can do from that, right? So that is one very important thing for these organizations to keep in mind. And lastly, from a timeline perspective, I think Tony and Mark already talked about it, but yeah, very, very true. I myself hear from some of our customers. They're like, well, 2026 and 2027, that's a lot of time. I think we'll think about it. We'll talk about it. And the reality is, there is not a lot of time, right? That's the reality here. And I think our message to everyone saying that is, if you haven't started with your planning for the implementation, do it today, right? I mean, you're already late. Like Tony put it, you're already behind, and we need to start it today.
So, to your point there, the fact, as Tony alluded to, some of the regulation come into effect in 2026. In fact, you're already behind. If you're not already collecting API metrics data for your patient access API, you are late, because in March of next year, you have to report on this entire calendar year's usage and send that to CMS.
Absolutely.
Absolutely. So how many times have we heard whenever a mandates come up by health plan that we have a lot of time, and only to know that as we get closer to the deadline, everyone's looking out for solutions and partners and to take care of them. Fair point.
Well, Nitin, the other thing there is there are other regulations that come into play. What we haven't talked about is the threat, right? And the pain that could come, because the way the information blocking rules have been written, you've now got payers potentially interacting and exchanging data. You've got payers and providers. And if you are sitting there saying, I'm not going to do that, how long is it going to be before there's $1 million fine coming down on you because you are information blocking?
Absolutely.
Right. And I think another thing to add to it too, some of the payers may think because there's a new administration that these dates may be changed, but I want to point out that both rules were bipartisan. The first rule came out under the Trump administration. The most recent one came out under the Biden administration. This has been an area where both Republicans and Democrats have really come together. So don't expect, because of an administration change, that this thing is going to be delayed for any particular reason.
Fair point. Not just to take this as a mandate, but this is a building block towards the transformation that this healthcare industry needs. That's how I think everyone in the ecosystem needs to take care of. Good. Thank you so much for this first section. Actually, just kind of warming up with respect to what these mandates are, why it is critical, and so forth.